My name is Aman Chauhan. I'm one of the medical oncologists here, and just trying my bit to help our wonderful neuroendocrine tumor patients and community. Thank you so much for taking your time, precious time off, and join us on this beautiful meeting. The task given to me today is actually Dr. Das was supposed to do this talk. And unfortunately had to leave, so maybe we'll have him introduced to you guys. He's a wonderful up-and-coming net oncologist at Vanderbilt. But I will do this talk instead of him. And I can sing in the meantime. You all understand Hindi? I do Bollywood songs. Okay, wonderful. We are back on. All right, guys, so these are some of my disclosures. All right, before we go into complications of carcinoid syndrome, what carcinoid syndrome is, and how do we manage it, let's do a little bit history lesson, right? We build on history, we build on pioneering work of previous generations. So Dr. Erspemer, you can see on the left-hand side, yes. He discovered a chemical, a substance, which was secreted by EC or enterochromaffin cells, and he named it entramine. He kind of started noticing that this particular chemical has some properties which helps regulate, and we'll talk about that in a bit. 10, 12 years later, another set of doctors, completely independent in a different place, different country, Dr. Rappaport, Green, and Page, they discovered a vasoconstrictor. Vasoconstriction means blood vessel squeezing in, okay? Vaso, blood vessels, constrictor, squeezing in. So a chemical which induced that spasmodic constriction, and they named it serotonin. And it took somebody, another few years to figure out this entramine stuff and serotonin is one and same thing. So who should we give credit for serotonin? I think it's fair to say everybody. They've done really pioneering work in isolating what this is, and that was the stepping stone for us to figure out if somebody's having flushing and diarrhea, what is causing it. If we didn't know all this, there's no way we could then later on monitor it and treat it. So kudos to all these giants in the field. So what does serotonin do? Serotonin is our friend. It's not always our enemy. All of us make serotonin in our GI tract, in the blood cells, in the brain, and we need a little bit, some amount of serotonin to do normal function, right? So for example, in GI tract, the role of serotonin is some of these nerves release a little bit of serotonin, and we call it neurotransmitter. So this is how our body interact with different organs. So nervous system interacting with the gut, right? So if our nervous system has to tell our gut, okay, I've just ate, I need the digestion process to start, the peristalsis, that means the movement of gut to start. How does it tell? Through these neurotransmitters. And one of the vital neurotransmitters is serotonin. What the serotonin would do is get the intestinal or digestive juices flowing, get the gut moving, and this is a very important part of that process. So serotonin is not always a bad actor, right? Similarly, you've probably heard serotonin is needed for mood regulation in the brain, right? Although the brain serotonin and the body serotonin, there's a blood-brain barrier. Fortunately, our drugs and the tumors don't really affect what's happening in terms of serotonin in the brain or the neurons in the brain. So, but the broader point is serotonin has a lot of normal physiological bodily functions. So how is serotonin made and where is it coming from? So we get serotonin from our diet, not in the form of serotonin. We eat tryptophan, which is an amino acid. Anything with protein, be it vegetables or meat-based products or anything, would have some amount of tryptophan. And this tryptophan is converted into serotonin. And the the scientific lingo of that serotonin is 5-hydroxytryptamine. So tryptophan is converted to serotonin in 2 steps, and we'll go over those 2 steps because those are very important. We have used our knowledge of those steps to start treating these patients better. Where is it primarily found? As I told you, 90% in the enterochromaffin cells in the gut. It's also found in platelets, as one of the blood cells helps in clotting, and of course in the brain, where it's helpful for mood regulation, right? So a lot of patients are on SSRIs, so basically selective serotonin receptor uptake inhibitors, so they're kind of helping with the mood. So serotonin has some role in there as well. This is normal distribution. I'm not talking about nets yet, okay? And it is really important for the well-being, happiness, and has multiple roles in the body, as I said. And serotonin, once it's made, it's not constantly being made. If it's needed right now, a body doesn't make it right away. It's made and it's stored in these bags within the cells, and then it's released when our body needs it. I think some of the NET patients would relate to that because it's not always the patient has flushing, right? Something triggers it and body or cells release it. So it's stored in these granules, okay? And again, neurons in the brain make their own serotonin, because this is one of the pet question. I'm sure somebody will ask, hey doc, I have too much serotonin, does that affect my mood? So that's a different process. And as of now, we are not convinced that the systemic serotonin affects what's happening in the brain and CNS based on that, because of the blood-brain barrier. What am I showing here is the gut. The gut wall under the microscope looks like this. It has like this finger-like projections, increases the surface area so that our body can absorb the nutrition, right? So in the middle of those, you see these enterochromaffin cells, the greenish kind, okay? And these greenish cells have these granules which store serotonin. And whenever it's needed, whenever brain tells a gut, hey, listen, we just ate, let the juices flow, let's start digesting processes, let's get the peristalsis going, and this is the process. This is all normal function, okay? Now, enough normal. We are here for neuroendocrine tumors, right? So let's start talking more about the pathological condition. So we also now know that neuroendocrine tumors make serotonin, okay? It is sort of like a vicious cycle, a self-fulfilling prophecy sort of like deal. So neuroendocrine tumors make serotonin, and serotonin then go out and stimulates more neuroendocrine tumor growth. So it's called autocrine loop, okay? So it's not like that serotonin is coming from thyroid or pancreas or somewhere else. These are the cells, the local cells are making it and then promoting their own growth, and it's sort of like a vicious cycle, right? And we know from some lab data that if you add serotonin into the cultures of neuroendocrine cells, that promotes their growth. So now we are talking about the pathological, the disease state, okay? So the overproduction of serotonin is a multi-step process. Now, let's see who was attentive here. See, I told you that tryptophan in the diet gets transformed into 5-HT in 2 steps, right? 5-hydroxytryptamine is the serotonin. So from food to serotonin, these are the steps, and it gets stored in these granules, and then the tumor would release it. Now, what releases it? Some people, coffee might do it, some people, stress might do it, some people, red wine might do it. Everybody has their own triggers. And sometimes it's just sporadic. You can't really put a finger on it. A patient have these bout of diarrhea all of a sudden, or flushing, or other manifestation of carcinoid syndrome that we will talk in a second, right? But understanding the pathophysiology of this pathway, we have now found ways to help our patients, and that's super interesting, and we'll kind of go about it in a second. So the effects of serotonin, elevated serotonin can do 2 things. One is it can give rise to something called as carcinoid syndrome. Very, very important. Causes tremendous issues to our patients, quality of life-wise and others. The other, which is not so much clear-cut, but theoretical, that it also impacts tumor growth. But it is yet, there's a gray area there, and there's debate going on that, but we definitely know elevated serotonin can cause carcinoid syndrome. So today, I'll be mostly talking about that aspect of serotonin and carcinoid syndrome and how to manage that, okay? So what is carcinoid syndrome? Now, you've probably heard in the morning from Dr. Anthony's talk that neuroendocrine tumors are not all same. One way to classify neuroendocrine tumor is a functional neuroendocrine tumor versus non-functional. About maybe 15-20% of neuroendocrine tumors are functional neuroendocrine tumor. What do I mean by that? That these 15 to 20% net patient can secrete certain hormones. And these could be serotonin, this could be VIP, vasoactive intestinal peptide, this could be insulin, this could be glucagon, this could be somatostatin. There's so many, and there are many that we haven't yet discovered. But by far the commonest one is serotonin, okay? And the carcinoid syndrome is the syndrome complex of elevated serotonin with the background of neuroendocrine tumor and one of these clinical manifestations. So that together is called carcinoid syndrome, okay? And what are these clinical manifestations? These could be flushing. As you can see, I've put them in the descending order of prevalence. So the longest bar is flushing. So the most commonest complaint of patient who has functional net with high serotonin would be flushing. But not everybody has to have flushing. That's the unique thing, okay? Patient can have no flushing but tremendous diarrhea. That's the second most common. Actually, diarrhea might not be the most commonest, but is most problematic for our patient. It has affected quality of life, the financial toxicity which comes with the effect of work, and so many other things. Then elevated serotonin can affect heart, carcinoid heart disease. I'll touch a little bit on that a little later because that is very important. Cramps, edema, that is swelling of legs and arms, wheezing. That wheezing is that noise that people make when they have asthma-like, that is wheezing. Why? Because the bronchioles, the airways, they constrict, they become narrow. So wheezing can happen, cyanosis, the turning of blue, the fingers and toes and the tip of the nose, and arthropathy, the joint pains, the muscle pains and achiness, fatigue, all these are symptoms of carcinoid syndrome. So people in med school we are taught flushing, wheezing, diarrhea, but it is beyond that, okay? So these are the symptoms that can happen because of excessive serotonin, right? Today's talk is specifically about the complications that can happen due to markedly elevated serotonin. And the two important ones I would like to touch on is carcinoid heart disease. Pulmonary hypertension is a little bit intertwined with that. And the second one is mesenteric fibrosis. So fibrosis of the belly tissue, okay? We'll go over that. So let's talk a little bit about carcinoid heart disease. Up to 50% patients, and even more, with carcinoid syndrome, that means these are net patients with elevated serotonin and all those, one of those symptoms that we talked about, more than 50% of these patients are at risk of developing carcinoid heart disease if not managed properly, okay? Fortunately, in the current era, with proper diagnosis and treatments, we are seeing less and less and less of carcinoid heart disease, okay? Because we are detecting them sooner, we are treating the serotonin, we're lowering the serotonin, we're making sure the patients are well taken care of. But it's not unusual that once in a while we do come across patients where this kind of slept through the cracks and nobody was kind of watching for it or wasn't aware of it, okay? And that's one of the reasons why we do these things, is not just to educate patient community, but yesterday we educated physician community about these very, very rare things, right? So they don't miss it. So excessive serotonin production by the tumors, and it's usually the metastatic tumor. So if the tumor is early stage, usually don't make serotonin in that quantity, or if it makes the serotonin, it goes through the liver, and liver sort of breaks it down, so it never reaches the systemic circulation. But if liver has a lot of liver mets, that's where a lot of serotonin get bypassed and then spills into systemic blood and then exposes the heart. And what we see, if the hearts get exposed, you see these symptoms. Valvular heart disease. It literally chews up the valves on the right side especially, okay? And so valvular heart disease, a tricuspid valve gets destroyed by high levels of serotonin, okay? And if the valve gets destroyed, then you start having the backflow of the blood, which we start calling right-sided heart failure. Patient will start developing edema. So anytime a NATS patient, a carcinoid syndrome patient has swollen legs, especially it's coming up, that's a bad sign, okay? And you need to get evaluated for heart conditions right away, okay? But the other things that can happen is effect on the muscle of the heart, effect on the rhythm of the heart, arrhythmias. So the heart beats in a regular rhythm, right? But serotonin can also affect because of the fibrosis, etc. Patient can have arrhythmias, etc. But the number one issue here is valves. So that's why echocardiogram is very, very important for baseline assessment. Now there is some old data which tells us why do we need to study this condition? Because if there is more than 10-fold increase in level of serotonin, the mortality is almost doubled. That's very important to know, okay? So it's a serious stuff, right? So if we do not get our serotonin in control, we are at risk of developing these complications, which then later on leads to increased morbidity and mortality. The survival dips down. Now I have to say, these data, see this is published in 2011, so this data is culmination of all the prior years before that, when we had rarely very few tools in our kits to control the disease, to lower the serotonin. So I suspect that in next 5-10 years that we will see a lot more improvement in these sort of situations, okay? So if, let's suppose somebody did develop carcinoid heart disease, what do we do, okay? Prevention is always better than cure, and we always strive for that. And that's why we check serotonin levels. So if you are coming to our clinic or somebody else's clinic, you will see your doctor would do either a spot blood test for serotonin or the old school way of doing 24-hour urine 5-HIAA. By the way, that is the gold standard, is the most accurate way to do it, but it's also pain in butt, right? One of my old mentors, Dr. Waltering, used to say, lug the jug. So, but now we have a pretty accurate way of doing it in the spot. You just have to be careful because sometimes the spot has to be a little off, because what if you're flushing at that time, it could be a little bit falsely elevated. But we have some data coming from Mayo Clinic, Dr. Thor, and I think, and we'll ask him the question again, but I think he's quite convinced that it is pretty good. It's pretty good, very close to kind of the real urine test. So we at least in Kentucky, we do it here. A lot of our patients traveling across state lines, and it's just not realistic to lug the jug, right? So, so that's one. I don't know, what would you say to the airport people? Hey, listen, no drinks allowed, right? Okay, this is homebrew. Okay. I see a career in stand-up. Okay, so it's very important to first recognize. But let's suppose somebody fell through the cracks, or the disease was so aggressive that the elevated serotonin did cause some cardiac damage, and now patient has carcinoid heart disease, right? What do? You need to work very closely with the cardiologist, okay? It is a very important, urgent situation because carcinoid heart disease can be rapidly fatal, if not dealt immediately, right? So a cardiologist needs to be consulted, and they manage the heart failure part of it. If the valve is an issue, the valve needs to be replaced at the earliest. At the same time, the medical oncologists have to develop strategies to lower serotonin. And how do we do that? We have tools like somatostatin analogs. We have other tools which I'll talk a little bit. Zermello is one of them, especially if there are patients having a lot of other carcinoid syndrome, diarrhea issues, etc. But more importantly, what's making these serotonin? It's the tumors, right? So we got to debulk the tumor. We got to reduce it. How do we do that? Either by embolization, the surgery, or other therapies like PRRT. So we have to have a multi-pronged approach, and it is a sort of a urgency. I would not defer it to, let me see my doctor in 6 months and see how it goes. The cardiac damage might be extensive enough that we can't do much if it comes to the end stage, okay? So very important. Again, I don't want to be all doom and gloom. This is very rare, and these days, the last time I saw somebody like this was several months or years back, okay? So that means we're doing a good job in preventing this complication from happening. All right, so that was carcinoid, heart disease, and many places now have actually dedicated cardiologists who are interested in cardio-oncology. I know Mayo Clinic has. Mayo Clinic has actually a very extensive one. They have multiple of 4 or 5 doctors. We at Markey just started this this year, where there is a cardiologist who has a dedicated oncology clinic. So he only sees patients who are cancer patients on chemotherapy or agents which can affect the cardiac function. And I think that's where the science is moving, because it's getting more and more complex. Okay, the second complication I'd like to briefly touch on is mesenteric fibrosis. So what is mesenteric fibrosis? Mesentery is a tissue which holds your gut to this abdomen, okay? And excessive serotonin for a prolonged period of time can develop scar tissues in that mesentery. And what end up happening here, I don't know if you can appreciate it because of the resolution of there is this scar tissue here. So if somebody has a lot of tumors and scar tissues in the belly, what can happen? Your bowel can flip on it and twist and cause obstruction. And it's not an easy problem to solve. You can operate on this patient once and unblock it, and then there's more obstruction in the future. And unfortunately, it is not uncommon that patients with mesenteric fibrosis tend to have multiple obstruction to a point that you can't keep chopping up the bowel, right? It's a vital organ. So it is a bad complication to treat and manage, and most of our treatments, unfortunately, don't work as well in mesentery as they do in liver, lymph nodes, and other areas, because the blood supply to these mesenteric organs are very limited. So our treatments don't work that well. So it's a bad location, bad complication, although treatment doesn't work. Again, so the magic word here is prevention is better than cure. So we try to lower the serotonin to prevent all these nasty complications, and patients don't have to go through these terrible side effects or complications. There is some interesting research happening in England. I recently attended a lecture by a basic scientist who are trying to solve this mystery and develop therapies to help with mesenteric fibrosis. But we'll keep you posted. All right. And just a quick word on, I talked about elevated serotonin causing carcinoid syndrome and mesenteric fibrosis, but then I touched on that it can also maybe make tumor more aggressive. That is debatable, but we know from old data that patients with elevated serotonin do worse. So the survival curves are better in the patients who have lower 5-HIAA, which is the breakdown product of serotonin. So what this curve tells me is that it's always better. Our patients do better, live longer, if they have better control over serotonin. Now, why does that happen? Probably because we prevent some of these bad complications. But is there a role in the tumor are also a little bit more stable based on our preclinical data? Yet to be certain, okay? But more importantly, coming back to this pathophysiology slide. So, right, tryptophan in the diet, 2-step process gets converted to serotonin, gets stored in these granules, and then it's released through the blood. In the blood, it gives us all the nasty flushing, wheezing, diarrhea, all those carcinoid syndrome symptoms. So we have 2 opportunities to fix this problem. One is, can we stop this release process? Let it make it, but as long as it's not releasing it, we are good, right? And we have 2 drugs that can do that. Lanreotide and sandostatin. How many people know of these 2 drugs? Everybody. You don't need this talk, right? You got this. So we have somatostatin analogs, that's lanreotide and sandostatin, which can affect and stop this secretion process. But we also have another wonderful drug, which is a pill called telithrostat ethyl or Zermello, which blocks the manufacture process. Okay, so you're not able to convert that tryptophan into serotonin, and you are basically sort of eliminating the root cause of it. So both have this. They both has the effect on lowering the serotonin at the end. Let's talk a little bit about somatostatin analog first, the sandostatin and the lanreotide of the world, okay? So, back in the day, I think this is 1986, this was one of the first and major publications which showed that somatostatin analogs, this is a short acting that you inject in under the skin, some of you might know, for quick symptom relief, that had tremendous benefit in flushing and diarrhea, okay? And based on these data, as FDA approved sort of use or become standard of care to use somatostatin analog. I learned this when I was 1 year old, right? 1986. So this is wonderful, wonderful pioneering work. Since then, the science moved tremendously, right? And from patient needing to use this short-acting somatostatin analog multiple times a day, we were able to develop 2 drugs which patients only need to inject once a month. Huge improvement, right? So not only symptom control, these drugs also showed that it can slow the tumor growth down. And that's very important, right? So carcinoid syndrome, certainly very important, and they help with the syndrome or symptomatic diarrhea and flushing, but also important that they control the tumor growth, all right? So PROMADE was a study, international randomized study done to study sandostatin, and more recently, Clarinet was studied between 2006 and 2012, which studied lanreotide in the same patient population. And I'll kind of briefly go over Clarinet, which is the larger of the 2 studies and more recent one, and led to the approval of lanreotide. So it kind of studied about 200 patients. 100 got lanreotide and other 100 did not. Got placebo. At that time, the best supportive was placebo. So you heard Dr. Cohen, these placebo arms move with the time, right? And what we saw here, as you can see, the patient had significant benefit in terms of progression-free survival over the control arm. So roughly speaking, it's about 18 versus, I think, 29 months or something on that. So there was improvement, right? And this led to wide use of lanreotide in our neuroendocrine tumor patient population. Okay, so that was the secretion end of the things. The other target I told you guys was, how about we block the conversion of tryptophan into serotonin, right? Take the root cause away, stop the production. And then this particular drug, Zermello, was developed to block that particular rate limiting step in the conversion, and this study called Telestar study, where we have a stamp, Kentucky stamp on it, we contributed towards it. Dr. Anthony was the co-author on this. It studied this pill called Zermello, which you take 3 times a day if you have carcinoid syndrome diarrhea, which is not responding to somatostatin analog, sandostatin or lanreotide. You're still having 4 and more bowel movements. Then we have another tool now in our box, which we call Zermello. It's a pill. And as you can see in this particular study, patients who were on placebo, serotonin didn't change. Of course, it won't change, right? You're not giving anything. But patients who were getting 250 milligrams of Zermello showed significant decline in their urinary 5-HIAA, which reflects serotonin. It's a breakdown product of serotonin. And if you get even higher doses, there'll be even higher reduction in serotonin. This was very promising. And it correlated with reduction in bowel movement. So the black line is the bowel movements in the placebo group, and the green and the blue line shows reduction in bowel movements in the treatment group. Based on this data, FDA granted approval to Zermello in 2018 for use of carcinoid syndrome diarrhea. So in summary, serotonin overproduction is a driver of carcinoid syndrome, okay? Serotonin plays an important role in carcinoid heart disease, mesenteric fibrosis, pulmonary artery hypertension. That's why if somebody has a markedly elevated or elevated serotonin or is clinical symptoms of carcinoid syndrome, I definitely like to get sort of baseline echo just to kind of make sure what is our starting point. Subsequent echocardiograms are case by case. We touched on that in the morning a little bit. Serotonin has demonstrated some effect on tumor growth based on our preclinical data. We yet to ascertain that in the clinical studies. But it's very important. The control of serotonin exposure is important, not only to improve the quality of life, but also the longevity of life. So with that, I'd like to conclude my talk. Thank you so much for your attention. And I would like to, I would like to,